So we will now break for tea and reassemble at 4 p.m.
Contribute, and she was the organizer of the 17th annual conference of the Indian Academy of Geriatrics. Her special interests include a focus on medical education in geriatrics and has been developing a one-year hybrid course in geriatrics to enhance elderly care training for doctors. Dr. Dilip Matai is a senior consultant at Narovi Hospital. He was the previous dean and professor of adult infectious diseases at the Apollo Institute of Medical Sciences and Research in Hyderabad. He is one of the leading faculty in infectious diseases in the country and a resource person for multiple national and international level policies and conferences. His areas of interest include infectious diseases, specifically HIV and TB, medical education, and hospital quality systems. Welcome, sir and ma'am. Our first speaker for today is Dr. Patrick Russell. He is a specialist general physician at the Royal Adelaide Hospital. He has served as director of the South Australian General Medicine Advanced Training Scheme and also as vice president of the Internal Medicine Society of Australia and New Zealand and president of the South Australian Association of Internal Medicine. His areas of interest include resident training and education, opioid prescription, and polypharmacy in older populations. Today, he'll be speaking on overdiagnosing and deprescribing in geriatrics.
Thank you. Can you hear me okay, I hope? Greetings from South Australia. I was going to limit my presentation to deprescribing medications. I'm a general physician at the Royal Adelaide. I'm grateful to present this on behalf of our team. This story is about trust, and it's about medication safety for vulnerable older people. We're passionate about medication safety, and like you, as bedside clinicians, the vast majority of our interventions involve prescribing medications, and patients trust us to prescribe the right drug at the right dose and the right time in their lives. And they trust we will not be unduly influenced externally by pharmaceutical companies or advertisement, or internally by bias or inertia. Doctors generally know a lot about when to start a medication at a certain hemoglobin A1C, for example, or a certain sustained blood pressure on multiple readings in a patient who's hypertensive, or certain symptoms. We've got that part down well, when to start. We know much less about when to stop, how, and for whom. Therefore, as a person rolls through life, picking up various medications as they do, because that's what the guidelines say we should do if we want to be a good doctor, and I want to be a good doctor someday. So I don't just stand there, I prescribe. It's no surprise then that most patients approach the end of life exposed to polypharmacy. Inappropriate medications might have been appropriate for an individual patient a few years prior, antithrombotics, for example, or antihypertensives, or cholesterol-lowering medications, or medications for symptoms that simply no longer exist, long-acting nitrates, for example, in someone with chronic stable angina. But polypharmacy is also a challenging area to investigate because of the statistical noise. Meals on Wheels, a community service here to deliver food to someone housebound, has a very strong association with death and hospital admission, but there's no causal link. Similarly, how much of the negative press around polypharmacy is due to reverse causality. So when we're talking about deprescribing, generally we mean stopping or reducing with the help of someone informed to make things better. But does it really improve outcomes? Difficult to know. Now, the slides are advancing a little bit faster than I can keep up with, but I'm going to try. Prescribing medication for each of the groups here listed: children, robust adults, or frail people. Prescribing medications for each of these groups will be different. Physiology is different for each. And before I start a medication for any of these various patients, I must consider the whole person. And considerations for deprescribing in the older patient ought to be very similar. So does it achieve its desired effect? Multiple systematic reviews say no, that it does not improve mortality, readmissions, or quality of life. But at the same time, there are multiple expert opinion pieces and guidelines that say we should deprescribe medications anyway. These editorials and guidelines are based on heterogeneous studies. For example, who is old, who is older, and who is considered very old. And what was the original indication for the medication? That is, what's the original risk we were trying to reduce? We view this lack of clarity as an opportunity to ask and attempt to answer certain questions. And our research question was this: when an older, I'm sorry, it seems to be advancing anyway, I beg your pardon, I'm going to try to hold it back. Our research question was, when an older medical inpatient is discharged to a nursing home, does it help to cease or reduce some of their long-term medications? We published a small pilot study in 2019, and we built our research capability from there. We used REDCap, and I'm sure you're using REDCap and Valor. We were one of the last on the planet to come to that party using REDCap, and we had doctors consenting and entering basic demographic data, and clinical pharmacists entering medication data. This was an observational study that was a follow-up study from our pilot, and all participants in this study received routine care. Medications on admission and discharge were entered in this database. Discharge medications were categorized as ceased, unchanged, or total daily dose increased or decreased. We wanted to understand whether inpatient deprescribing had any effect on mortality or readmissions or quality of life. We approached 265 patients, consented about 90% of them. Many of them required third-party consent due to cognitive impairment. Our cluster sizes ranged from 5 to 126 patients across these 5 hospitals. There were participants who were excluded. Some died before discharge. Some were invalid entries. It left us with 180 participants with complete data, and these were categorized as either in a deprescribing group or not deprescribing group. And the deprescribing group, there were about 2/3 of them had medications deprescribed. What we found is in the so I'm going to move this just a bit. This middle column, the deprescribed group, there were no differences in death or readmission or quality of life at 30 and 90 days, and nor were there any differences in the number of inappropriate medications as judged by the Beer score. What this did give us the opportunity was to recognize that there are a lot of medications that might be inappropriate in a certain context that aren't included in the Beer list. For example, it includes no antihypertensive medications. As an example, I saw a man today on post-take ward rounds, 93-year-old man, on blood pressure medicines and a diuretic, and his rivaroxaban for his atrial fibrillation, and some atenolol for some atrial fibrillation for rate control. None of these medications would have been considered inappropriate on paper, and yet he was hypovolemic, slightly hypotensive, and bradycardic. All of them were inappropriate for him. This slide shows a number of the missed opportunities to cease medications. statins and long-acting nitrates, for example, or the ever ubiquitous proton pump inhibitors. And our results were that at 1 year, the mortality was 42% with no significant differences between these two groups, but that deprescribing certain classes of medications might be associated with worse mortality if we stopped antihypertensives, for example, or statins. Again, this might be like Meals on Wheels and reverse causality. I suspect those patients who had these medications ceased, antihypertensives and statins, probably looked the worst at the bedside and looked like they were most likely to pass away. But it's hard to know. Readmission rates were similar, and there was no deterioration in quality of life when medications were deprescribed. So the Oxford question is, so what? This was non-specific deprescribing. Who cares? And it's similar to non-specific prescribing. For example, if I said people just need to take more pills, it doesn't matter what kind, just take more pills and it'll help your infections and heart attacks and strokes, and that'll be better than doing nothing at all. It should be a silly comment to make. And non-specific deprescribing, like we conducted in that study, is very similar. The who, the what, and the whens are extremely important when searching for specific answers. So our conclusions here were that deprescribing seems to be at least safe, despite some of the results in the latent profile analysis, but that antihypertensives and statins, deprescribing them was associated with increased mortality. But it highlights the need for randomized studies of de-intensification of antihypertensive medications in frail older people. So I'll talk, the rest of this, these slides are about deprescribing antihypertensive medications. 6 of the 10 most commonly prescribed medications for older people in North America lower blood pressure. That is, antihypertensives contribute to polypharmacy, but they're often considered essential and beyond deprescribing. Confounding a careful sifting of the evidence are the evolving definitions of who has been considered old, leading to unclarifying distinctions such as very old or oldest old, as well as the differences in the way blood pressure was measured and the threshold for what was considered hypertension. In the 1970s, what it was considered a normal blood pressure would be very different from what we consider it today. It ranks right up there with the distinctions that we make in polypharmacy and hyperpolypharmacy, or throw in there, if you'd like, uber polypharmacy, because none of these distinctions really matter much. Antihypertensive medications are actually very good medicine. Franklin Roosevelt, president in the U.S., died of a hypertensive stroke in 1945. At that time, practice of medicine was dominated by expert opinion that held that a high blood pressure was necessary for adequate end-organ perfusion and not part of the problem. A decade or two later, as treatment options expanded, comparisons were made between people whose blood pressure was treated and those without treatment, and these early comparisons suggested patients with untreated hypertension fared worse than those whose blood pressure was better controlled, with or without symptoms and without consideration of age. And then along comes a VA cooperative study in 1967. It was the first randomized control trial, and they enrolled essentially people with malignant hypertension, 143 men, average age was 51, severe hypertension, randomized to receive treatment for their blood pressure or not. And no surprise, after 1 year, the study was terminated early because of the substantial reductions in clinical outcomes in the treatment arm. I throw this slide in there because it's important to remember that blood pressure medications in hypertensive patients are very helpful. The VA study showed at one edge of the spectrum, those people with severe disease, that treatment was beneficial, and it paved the path for other studies that showed treatment helps reduce events, even when those patients even for those patients with what was then called benign essential hypertension and not routinely treated. But over time, as there were reductions in what was considered a normal blood pressure, and randomized control trials moved from placebo in the control arm to using the control arm as conventional therapy, and the differences between the treatment groups and the control groups narrowed, leading to these ever-expanding sample sizes required to adequately power a study. The biggest one was the all-hat study, enrolled 33,000 patients, and pushing further downward, ever downward, the threshold of what we consider normal blood pressure. And then these trials evolved to focus on older people, truly older people. This first major trial was the hypertension in the very elderly trial, the HIVET, which excluded anyone less than 80 years of age. And you would probably know of the SPRINT study, the systolic blood pressure intervention trial, where a third of the participants were older than 75 years of age. And they all found that lower is better. But is there such a thing as too low? Well, lower is better only up to a point as a person ages. There's changes associated in their physiology and their cardiovascular morbidity and mortality compete with other potentially modifiable risks, including polypharmacy. Aging brings with it physiological changes in metabolism and elimination, important considerations when counting medications and assessing dose. Bone density decreases, muscular strength flags, brain atrophies, heart and blood vessels become stiffer and less compliant. This older, frail patient is a different adult from this young, robust, middle-aged patient of 50. The cardiovascular changes accompanying aging underpin commonly encountered blood pressure changes, such as an increasing systolic blood pressure and decreasing diastolic blood pressure. So is there such a thing as too low? Yes, there is. There always has been. Even these early epidemiological studies identified an upward inflection in the mortality curves that resembled a slanted letter J. I was always taught that it was a diastolic of less than 60 when mortality goes up. But in fact, this curve moves backward and forward on the graph. Certain complex older people encountered routinely in a clinic, hospital, or nursing home were often excluded from the randomized control trials showing benefit from intensive blood pressure control. Cohort studies of these more complex patients showed a very different truth, that the point of too low, that is here at this bottom, the point of too low might move upward to the right on this graph, and that blood pressure targets for adults might be too low for selected older people. Not all older people are the same. Some are burdened by frailty superimposed on cardiovascular disease and limited life expectancy, which leads to a flurry of observational data over the last several decades. And it's begging your pardon again. Bear with me. Observational data like this from a Swedish study published in 2008, where investigators enrolled half of all people within a county older than 85 years and all people older than 90 years, and followed participants for 4 years. And participants were categorized by their baseline systolic blood pressure. They found mortality was greatest in those with the lowest baseline systolic blood pressure, begging the question, is having a low blood pressure late in life beneficial? This study, published in 2010, 880 patients followed for as long as 10 years and separated for analysis into a younger group, lower age group on the left, and an older group on the right. While the older group did not enjoy the same survival, as you can see here, as the younger group, there was an inverse relationship between blood pressure and mortality after adjusting for confounders. These investigators found the risk of mortality increased for every 10 millimeters of mercury decrease in the blood pressure. How do we then reconcile this with the bigger studies like HIVET and SPRINT that showed a benefit with more intensive therapy? And it could be is that the patients in the graph here were the type excluded from a randomized controlled trial like HIVET and SPRINT. Another observational study, older people living in the community might not fare well with intensive blood pressure control. Investigators reviewed a national database in the United States called the NHANES. It's a big registry, included 2,300 non-institutionalized people, 65 years and older, and it linked mortality data with a physical examination and gait speed as a measure of frailty. The data extended over a 3-year period in the late 90s and early 2000s. The more robust fast walkers who were also hypertensive up here at the top, if they were also hypertensive, a systolic above 140, they had a 35% higher mortality than those whose blood pressure was controlled, consistent with our conventional understanding of hypertension and mortality. For slow walkers, though, there was no mortality difference between those with higher and lower blood pressure. And for those who could not complete gait assessment, it was reversed. Lower blood pressure was associated with worse mortality than higher blood pressure. So what happens when you stop? First, this is not a new idea. People with hypertension might not need lifelong treatment for raised blood pressure. It was first proposed in the early 1960s in the form of small cohort studies of drug withdrawal and case series. Deprescribing blood pressure medication should be done as thoughtfully as beginning a new blood pressure medicine, considering the patient's goals and preferences, medical history, physical examination, recent blood tests, and overall prognosis. This is an age-old approach, and it's using the best available evidence. First, we consider the reasons an older person previously requiring blood pressure medications might not need them long-term. It could be that the original diagnosis of hypertension was based on inappropriate measurement. For example, in the setting of pain or distress, we often start antihypertensives in hospital only to find that the blood pressure is too low as an outpatient. Or perhaps conditions have changed. Sodium intake is reduced or body weight has decreased. Either might be related to anorexia as a geriatric syndrome. Or the blood pressure could be decreasing as part of a terminal decline, well documented in several longitudinal studies. If conditions have changed in the life of the older person, it is worth considering a trial of de-intensification. So how we go about this is to pick a suitable patient. The benefit of deprescribing antihypertensive therapy in older people is all about picking the right patient. The first situation might be when the blood pressure is already well controlled. In a recently published multi-center study called the Optimize study, beg your pardon, it was a randomized controlled trial. They looked at 570 outpatients older than 80 years, randomized to stop one of their blood pressure medications or continue usual care. Participants had to have a systolic blood pressure less than 150 at enrollment, and they needed to be taking 2 or more antihypertensives. The mean systolic at the time, at the beginning, was 130, and mean age was 85 years. At the 12-week follow-up, both groups had an equal percentage of patients who maintained a systolic less than 150. That equal percentage, that's 85%, with a mean change in the systolic blood pressure of 3.4 millimeters of mercury in the deprescribed group. So if you stop, yes, the blood pressure will go up a bit. Another suitable patient. Circumstances in which one might discontinue blood pressure lowering medications include a life-threatening adverse drug event or acute intercurrent illness associated with hypotension. For example, sepsis in an inpatient, blood pressure's dipping down to systolic 105 or 110, stop the medication and restart it as an outpatient if you must. And then, of course, a new life-limiting diagnosis. Also, new frailty. It doesn't have to come on slowly over time. A pneumococcal pneumonia complicated by sepsis can render frail a once very robust older person. Midlife, untreated hypertension is associated with later development of cognitive impairment. This is well established, been reproduced time and again in long-term longitudinal studies, emphasizing the importance of aggressive blood pressure control in middle-aged adults with hypertension. I'm not saying that blood pressure medicine should be stopped in all adults. But once cognitive impairment is established, intensive blood pressure control might be counterproductive. Cognitively impaired people are often excluded from randomized control trials. In this publication in JAMA in 2015, European investigators reported more rapid cognitive decline in older cognitively impaired patients treated intensively on antihypertensive medications to a systolic less than 130. If they were treated intensively, it was associated with more rapid cognitive decline compared to those not treated intensively. And this set the stage for this Dante study that was published later that same year. Investigators in the Dante study hypothesized that ceasing antihypertensive medications might help increase blood pressure and cerebral perfusion and therefore cognitive function. It didn't work. Their blood pressure did go up a bit by 5.4 millimeters of mercury. Cognitive function did not improve. But there was a take-home message. Antihypertensive medications can be ceased, and follow-up is important. Finally, as an older person moves from mild cognitive impairment to dementia, the blood pressure might change independent of any medications. The onset of dementia can be associated with a lowering of blood pressure and continue to decrease as the dementia worsens. The patient might not need medicine anymore. And that's it. That's all I've got. If you want any of the references, you can pull them off of this three-part series we wrote for North American Pharmacy Journal, and I think it's readable for a busy clinician. Blessings on CMC Velour, and I thank you for your time.
Thank you. Thank you. Thank you very much, Dr. Russell. Really inspiring talk, considering that as a physician, I have never deprescribed, but you have brought out a case for deprescribing. Thank you. We have a few questions that you might need to dwell upon. What are the physician barriers to deprescribing, and how can we facilitate deprescribing?
Gracious, this is a complex. This is not an easy question. I think that you could probably answer this for me, and that the common things are just that I'm busy, and that there's also it's a matter of taking time to consider each of the medications that I'm prescribing, and talking with the patient, being familiar with the literature behind, for example, being familiar with how long I need to treat someone for their hypertension to achieve a benefit. Being familiar with the observational evidence that shows that some people, some old frail people, seem to do better with a slightly higher blood pressure, or that treating intensively with blood pressure medications in older cognitively impaired patients is probably doing them a disservice. I mean, just being familiar with the literature is a big barrier, as you know, because it's just hard to get around to reading everything that I'm supposed to read. And then patients sometimes don't want you messing with anything. which is okay. I can just say, look, if you were my mom or if you were my dad, I would stop this medicine. Why don't we stop it and you follow up with your general practitioner and see how your blood pressure is in a month. And then there's also the professional courtesy. This is professional courtesy that I don't want to offend someone else by stopping a medicine that they prescribed. I think those are some of the barriers.
I agree with you. You can't tell somebody you've been taking this medicine for this long. Now you can stop it because you have crossed that barrier. You'll open yourself up to several questions which you cannot answer. One more question. Does deprescribing open us to litigation?
This is a common clinical scenario on the wards. I go see an elderly lady. She's come in for falls. She's on anticoagulant and antiplatelet therapy. And I say, this is not going to fare very well for you. We should stop at least the antiplatelet therapy. How about we stop the clopidogrel? And then the cardiologist comes in and I politely say, hey, what do you say we stop the antiplatelets? And the cardiologist, of course, says, no, I don't want to stop the platelets because I'll see them when they come back in with a thrombosed stent. But I think being familiar with the evidence, and the evidence would say that elderly woman needs her antiplatelet therapy stopped and leave her on the anticoagulant therapy. That's what the evidence says. But I don't think it opens up to litigation, but people can sue for whatever they want to sue for. I don't know of like scientific evidence that's been published that shows that you must do one or the other. I think people want me to do my level best and to treat them like I would my family. But if they didn't want to stop it, well, by all means, keep taking it.
Thank you, Dr. Patrick. Just a comment. Actually, follow-up is a problem. They'll stop the drug and they won't go for follow-up or measure blood pressure. That's also seen. That is just a comment. So maybe that's the scare that physicians have to stop the antihypertensive. I'm not talking about the other drugs. The last question is a pure geriatric question. What is the effect of cultural differences in who is considered geriatric on health and treatment?
Oh my goodness, that one's a hard one. I will defer that question to you, Madam Dr. Sareka.
The next speaker probably will answer that question.
Yes, I'll defer that. It's difficult in Australia, and I'm not Australian, obviously, but in Australia, for example, the Aboriginal people, hey, a 55-year-old or 60-year-old Aboriginal person might be treated as if physiologically they were 80 years old. And so I think being aware of these cultural differences and ethnic differences is really important. But I won't be able to make any comment at all about how things are in Vellore.
Thank you very much, Dr. Russell. We look forward to the India-Australia match. Okay.
I'm American. I don't know anything about cricket.
Thank you so much.
Thank you. Blessings on you there.